So as we know, burn injuries are among the most devastating all injuries and major global public health crisis. And it is the fourth most common type of trauma in the worldwide. Mainly low and middle economic countries are burns more common, but these are mostly intentional burn, around 35%. But in Western country, the burn most common is traumatic burn is most common, unintentional burn injury are most common. Mechanism mainly is five mechanisms are there. Most common is heat because the thermal conductivity of the skin is low, and most thermal burns involve the epidermis and part of the dermis. The most common thermal burns are associated with flames, hot liquids, hot solid objects, and steam. Electrical discharge that causes disruption of the cell membrane, and the function of the cell membrane damaged by electrical discharge and causing the burn. Frictional injury can cause the burn by combination both mechanical disruption of the tissue as well as the heat generated by friction. Chemical burn caused by acoustic reaction, including alternation of the pH, disruption of the cellular membranes, and the direct toxic effect of the metabolic process. Systemic absorption of some chemical is life-threatening, and local damage can happen. I'm coming to details later. And radiation, radio frequency energy or ionizing radiation can cause damage to the skin and tissues. So classification of burn, so we can divide the burn according to the source or the causative agent, like inhalation burn, like thermal burn, chemical burn, electrical burn, like this. But according to depth, actually this is more specific to better to describe for the management point of view. Divided mainly in three types: superficial burn, partial thickness burn, and full thickness or deeper burn. So superficial burn is mainly red and dry burn and branches with pressure, very painful, healing time 3 to 6 days. Whereas partial thickness burn divided into two: superficial partial thickness and deep partial thickness. In case of superficial partial thickness, blister formation is there and it is painful and branches with pressure. Healing time 7 to 21 days. Deep partial thickness, blisters, wet or wax dry, variable color, blanching with pressure, may be sluggish, painful to pressure only, more than 21 days. Full thickness burn, this is deep pressure, less pain in these cases. Actually, when there is a deep type of burn, deep partial thickness burn or full thickness burn or deeper injury, there is an injury in the nerve tissue also. So that causes the pain less, means leads to pain, that is less pain in case of this type of burn. Whereas the pain is more common in superficial or superficial partial thickness burn. Earlier this is known as 1st degree, 2nd degree, 3rd degree and 4th degree burn. This is same type of things. Superficial thickness, that is 1st degree, partial or intermediate 2nd degree, full thickness 3rd degree, and 4th degree what is the exposure of bone is there. Now method of estimation. Two most common used method for assessment of the percentage of total body surface area in the burn are the Lund Brothers chart and rule of nines. The first one is much more accurate method estimation total body surface area for both adults and children. This is the Lund Brothers chart. It shows that according to area, head, neck, trunk, upper limb, forearm, hand, and thigh, leg, foot, buttock and genitalia. They are divided according to years: birth to 1 year, 1 to 4 years, 5 to 9 years, 10 to 14 years and adult. So according to this, we have to measure the total percentage of the burn affected in the body. This is the adult. For adult, this is the modified Lund Brothers chart. Now rule of 9, this is the most commonly used in day-to-day practice, and it is for adult assessment only used for rule of 9 rules by Walsh. So for adult assessment, the most expeditious method to estimate total body surface area in adult is rule of 9. The head represents 9% of total body surface area, each arm 9%, each leg represents 18%, anterior 9 and posterior 9, anterior and posterior trunk each represent 18%. So if we calculate all this, it comes around 99% and 1% for genital region. So it comes total 100%. Now severe burn, that is more our concern. Severe burn is the one of that, and that is complicated by major trauma or inhalation injury, a chemical burn, high voltage electrical burn, and in general for adults, any burn encompassing more than 20% of the total body surface area, excluding superficial burns. Management of the patient with a severe burn injury is a long-term process, and that address the local burn wound as well as the systemic, psychological, and social consequences of the injury. In spite of improvement and treatment, to even today, the mortality rate of severe burn is very high. This is the burn center referral criteria, and this is as per American Burn Association criteria. Here is the partial thickness burn, and this is, I just want to mention one thing: the partial thickness burn greater than 10% of total body surface area is the referral center for ABA guideline, as per ABA guideline. But for us in Indian scenario, if we go through the guideline, it comes 10% for severe burn. They are telling in partial thickness burn more than 25% is the referral criteria for burn center. In case of extreme of age, less than 10 years and more than 15 years, this comes around 20%. But for deep burn, deep thickness burn, it comes we have to refer the patient when total body surface area causes more than 10% in case of deep burn only. So not for partial thickness burn in Indian scenario. This is for American purpose. Rest of them are remain same. The burn involve face, feet, genitalia, third-degree burns, electrical injury, chemical inhalation injury, patient with pre-existing medical disorder. These all things remain same. Now comes to management portion. So management of the burn is as per advanced trauma life support guidelines for assessment and stabilization of airway, breathing, circulation, disability, exposure, and environmental control. As we seen in ATLS guideline, as per ATLS guideline, primary survey, resuscitation, secondary survey, and specific treatment. Primary and secondary assessment for the severity and the extent of the burn and evaluation associated life-threatening injury are promptly performed. Ambient room temperature should be increased to prevent hypothermia and reduce the patient's stress response. Airway and breathing. So as we know that main part is in ATLS guideline. In every case, we have to look for airway and breathing. First of is our most priority. So about 1/3% of the burn injury have concomitant inhalation injury. So pulmonary related complications following burn and inhalation injury are responsible up to the 77% of deaths related to burn injury. Carbon monoxide poisoning should be present in any patient who present with following smoke inhalation, and administration supplemental oxygen FiO2 of 100% is indicated. So early intubation is justified for any patient suspected with inhalation injury and signs of respiratory distress. So how do we know the inhalation injury? There is a history of burn in the enclosed area, particularly by history. In examination, if we see any injury or burn in face or oral cavity, there is shoot in the oropharynx, all these things are indicated of the suspicion of inhalation injury. And we have to see whether there is presence of respiratory distress or not, like stridor, use of axillary respiratory muscle, hypoxemia, hypoventilation, deep burn to the face or neck, blistering edema of the oropharynx, we have to see. So for the patient with clinical features and suspicions of inhalation injury, we have to do a bronchoscopy to confirm the diagnosis of inhalation injury. It is recommendation. So now is nebulization. Aerolized bronchodilators are effective in several ways and should be given when wheeze or bronchospasms present. Clearing of the airway is the essential component in the management of the patient with inhalation injury. This can be achieved with a combination of inhaled pharmacologic agents like N-acetylcysteine, heparin, and mechanical means as such therapeutic coughing, chest physiotherapy, airway suctioning, early ambulation, and if necessary intubation with suctioning and therapeutic bronchoscopy. So we have the cleaning of the airway is important part. Now hyperbaric oxygen therapy in carbon monoxide poisoning. as we know, the carbon monoxide poisoning, when you suspect carbon monoxide, it has more affinity towards the hemoglobin. So there is a chance of hypoxemia, but with undiagnosed hypoxemia chance is much more there because SpO2 does not show any sign. So hyperbaric oxygen therapy is indicated when CO level, carbon monoxide level more than 20%. More than 20% in case of pregnant patient. Normally we will say carbon monoxide poisoning when the CO level more than 10%, but we have to give hyperbaric oxygen when its level more than 25%. Loss of consciousness, severe metabolic acidosis, concern for end organ ischemia, chest pain, ECG changes, altered mental status, all these things. Now, cyanide poisoning. The hydrogen cyanide is the gaseous form of cyanide. So, cyanide poisoning is rapidly lethal and unless treated with antidote. The thing of cyanide poisoning is it is difficult to diagnose because earlier there is a non-specific symptom like chest pain, abdominal pain, altered sensorium. This will be the primary sign of the tachycardia, tachypnea, high BP. This is the sign and symptoms of hydrogen cyanide poisoning. So skin may be flushed with cherry red color and neurologically seizure and coma as poisoning progress. Narrow venous and arterial PO2 gradients support the cyanide toxicity. Administration: when we diagnose the suspect the cyanide poisoning, we have to administer specific antidote when it is suspected. So hydroxycobalamin is the preferred antidote along with sodium thiosulfate 25%. If hydroxycobalamin is not available, then we have to give sodium nitrite. Most patients do not suffer long-term respiratory impairment following smoke inhalation. However, although their residual long-term sequelae may include tracheal stenosis, bronchiectasis, interstitial fibrosis, reactive airway disease, and bronchiolitis, all these things can happen. This is usually associated with severe injury. So, in case of airway,
what is the normal venous hemoglobin?
normal venous.
Arterial PO2 কত থাকে
100
থাকে না
8
times of হ্যাঁ হিসাবে থাকে নরমালি হিসাবে তো জানি আমরা শান্তের একটা ব্যাপার আছে আর ভিনাস ব্লাডে যেটা আমরা SpO2 করি এটা কত নরমাল পারসন
75.
Yeah, it has to be 75, but 25% extraction হয় so the gradient is about 25.
Simple plus 2 PO2 and SpO2. PO2
minus SpO2. When you run it through blood gas machine, and you will get the SpO2. Yeah, so it will be the AO2 jagger VO2 also, but you are getting it from yeah.
So, in summary, for airway management and breathing for burn injury, we have to look for there is the presence of inhalation injury present.
I guess if your hemoglobin is bound to carbon monoxide, then it is not going to give the oxygen. So, what a point. It is not a great measure. I mean, you need to know the carboxy hemoglobin.
Exactly.
How do you know that?
Co-oximetry.
But normally, even generally the gas machine will have an added module. So you get the co-oximeter. And hyperbaric oxygen,
না এখানে তো প্রেসার হাই প্রেসারে
I mean, you see that the thing is, hyperbaric means when you are ventilating a patient, you are giving positive pressure. So it is actually hyperbaric. I mean, normal, so you are breathing at atmospheric pressure. If you are managing a patient of decompression sickness, সেখানে you need to put the whole body into a positive pressure chamber. কারণ অন্যান্য টিস্যুজেও তোমার ওই নাইট্রোজেনটা গন্ডগোল হচ্ছে, dissolving out of. So there you need to put that patient in a hyperbaric chamber. Whereas, but for carbon monoxide poisoning, you can just positive pressure ventilate the patient.
So, in summary, for airway management in burn patient, we have to look for any inhalation injury or presence or not. We have. So we have to look for any inhalation injury presence or not. We have to look for any respiratory distress presence or not, and the condition of the patient. according to that we have to manage intubation, early intubation. If the on doctor feel that there is a need for intubation, we have to go for intubation. There is no question for delaying the intubation. The airway management, the ventilatory management remains same as normal patients. Normal patient who needs the intubation, other medical patients, and the indication of tracheostomy is also same as normal other medical condition. There is no specific change in for burn patient. Actually, there is a much more study regarding this early intubation in burn patient and all. Till date, there is no sufficient data. There's anything improvement for early intubation or early any change of ventilation can change the outcome of the burn patients.
So, for practical purposes, what do we do?
Normal. I mean, if we need the patient needs the difficulty in winning, if we feel we can go for early intubation as we do for other cases.
Practically early is better because after 24 hours it's more difficult.
So
edema is there.
if the patient has been for some time in a smoky room, or you can see any oropharyngeal changes, if you see any soot or any erythema, etc., you just have to do an early intubation. And তারপরে it is going to become a nightmare. মানে তোমাকে তখন tracheostomy ইত্যাদি হবে। আর যদি এখানে পোড়া থাকে তাহলে tracheostomy itself is a nightmare. So early intubation, when in doubt,
Intubation early.
yeah. Also, it will help you manage the patient distress, pain, and everything, the situation. Okay, line করতে হবে, এই করতে হবে, যাওয়া পাবো, so it is best to মানে have things in a controlled situation.
Even like is
Absolutely.
পরে একদম পাওয়া যায় because there is too much of edema in the tissue. You just want to
Now come to fluid resuscitation. This is the most important portion of the burn because burn shock during first initial 24 to 48 hours following major burn is characterized by myocardial depression and increased capillary permeability, resulting large fluid shift and the depletion of the intravascular volume. So rapid aggressive fluid resuscitation to reconstitute the intravascular volume and thereby maintain the end organ perfusion is crucial. The thing is that we can't give less fluid. There is a improper resuscitation or inadequate resuscitation, but if we give more fluid, that's also seen the outcome is poor because there is chance of volume overload and other things comes in that place. So we have to give fluid as per optimal basis as per need of the patient. So the initial fluid of choice is balanced crystalloid, most commonly ringal lactate solution. Patient with major burn should have 2 large bore IV lines placed through the unburned skin if possible and may require central venous access. IV lines can be placed through the burnt tissue if necessary to avoid delay in the resuscitation. There is no such particular recommendation for the you have to follow this formula or not. It's requirement of the fluid according to patient condition. But we usually follow the Parkland formula and or modified Baxter formula is the most widely used guide to initial resuscitation fluid needs for the burn patient. So what is the Parkland formula? It is for fluid resuscitation requirement initial 24 hours of the treatment is 4 ml per kg body weight for each percent of the total body surface area burn given. Superficial burn are excluded from this calculation. Half of the calculated fluid is need to given in the first 8 hours and the remaining half of the half is given over the subsequent 16 hours. So this is the kind of example of Parkland formula. We have shown this the entire item that is 9% and anterior trunk is 18%. So total affected area is 22.5%. Now 4 ml per kg into percentage of affected area. 4 ml into 80 into 22.5, that's come around 7.2 liter. So we have to give 3.6 liter in first 8 hours and rest 3.6 liter next 16 hours as per Parkland formula. In case of child, actually the formula is not 4 ml per kg, it is 4:2:1 ratio. For first 10 kg it is 4 ml per kg. For next 10 kg it is 2 ml per kg and rest more than 20 kg comes 1 ml per kg. Now Brook formula, there is another formula for resuscitation apart from Parkland formula that is 2 ml per kg body weight for each percentage of total burn surface area in IV fluid. Rest remain the same, half and 24 hours. Now, resuscitation of severely burned in military casualty. This is in USA. They have divided the group into two groups. One is follow the Parkland formula, and other one is follow the Brook formula. As per Brook formula, they resuscitate the patient, and they have seen in first 24 hours the requirement of fluid is much less in case of those who follow the Brook formula, and the outcome remains same. So we can manage better. We can give less fluid with same outcome in case of Brook formula. If we follow the Brook formula, that is 2 ml per kg with percentage of body weight. Now, monitoring is important for fluid resuscitation purpose. Hourly urine output should be maintained at 0.5 ml per kg per hour. So, it is recommended when the total body surface area is more than 10%, better to put a Foley's catheter. Clinical sign of volume status such as heart rate, blood pressure, pulse pressure, distal pulse, capillary refill time, and color darker of uninjured skin are monitored every hour for first 24 hours. Specific laboratory measurements such as mixed venous gas and the serum lactate concentration are additional important guides to adequacy of the resuscitation. So it's all about the first 24-hour resuscitation. But after 24 hours, we have to give the fluid according to the needs, and we main target to maintain urine output around 0.1 to 1 ml per kg per hour. Confirming the adequacy of the resuscitation is more important than strict adherence to any sort of fluid resuscitation formula. Now, immediate burn care and the cooling. Any hot or burn clothing, jewelry, and other obvious debris should be immediately to be removed to prevent further injury and to enable accurate assessment of the extent of the burn. Sometimes when the blister is and edema is formation, it is difficult to remove all these things and complicate the things much further. Burn areas should be cooled immediately using cool water and saline soaked gauze. So for small and moderate size burn, cooling can minimize the zone of injury. Can apply saline soaked gauze at a temperature approximately 12 degrees centigrade for 15 to 30 minutes. Cooling tissue around 12 degrees centigrade during the first several hours after injury effectively decrease the pain from burns. Ice and freezing should be avoided to prevent frostbite, systemic hypothermia, and extension of the burn injury. Core body temperature is continuously monitored while cooling is performed to help the prevent hypothermia, especially when dealing with burn greater than 10% of total body surface area. Burn temperature, body temperature below 35 degrees centigrade should be avoided. Warmed IV fluid can be used to maintain core body temperature. Pain and anxiety management. So,
for this very purpose, normal cell can be used because we see it's an irritant.
Yeah, মানে কুলিংটা তো কোথায় করা যায় এখানে হয়েছে the primary site আপনার হয়ে গেল ওখানে তো নর্মাল জল দিয়ে করতে হবে তাই না আর আদারওয়াইজ আর নর্মাল সেলাইন দিয়ে এরা করে যখন এরা ডেসিটেশন করে ওইটা দিয়ে যায় বাট I think they are dealing mostly with the people so funny sensation at our time. And I know what you're saying, they jalete galapsiras na
What do you think the normal cell can be used?
হ্যাঁ সেটাই বলতে কিন্তু ওরা তো ডিফারেন্ট ডিল করে সেটা সুপারভিশন ট্রান্সফার অর্থে কি এসব করে
No, there was a dressing for normal cell can be used.
হ্যাঁ কিন্তু that is partial thickness deep or deep because in superficial ট্রান্সফার ওখানে যায় না whereas say suppose কারণ তুমি আচর কোথাও or first aid দেবে ওখানে তো কলেজ জল
তাহলে দিস বলা
হ্যাঁ এটা হ্যাঁ true সেটাই বললাম ওরা তো যায় আর
আপনি ওটা হাইপোটোনিক করার জন্য কি অবস্থা
আর বাহ মানে তোমরা একটু তো বোঝার প্রবল বা একটু এসব কিছু দিয়ে না সো ওই প্রবলেমটা চলে যায়
So you just use the fluid which is at hand.
but by the way I don't think everything is at hand article college is at hand
Yeah, it's
I don't want choice. Makes sense. When the hospital there was.
so you can either put it in বরফ না that is like অনেক না বরফ ব্যথা হচ্ছে বরফ দিয়ে দিয়ে সব কিছু দিয়ে বরফ দিয়ে দেওয়ার একটা ব্যাপার থাকে ওইটা that is
What now?
না ব্যথা না মানে একটা তো বরফ কিছুক্ষণ দিয়ে রাখলে the area becomes numb and এমনিতেই burn হয়েছে you don't know whether this is how superficial or how deep it is you might actually cause more damage আর যদি বড় এরিয়া হয় তাহলে তো হাইপোথার্মিয়া ব্যাপারটা ওরা একটু বেশি ওয়ারেন্ট থাকে। আপনারা যদি সেন্ট্রাল এসি টেসি অনেক এক্সপেন্সিভ ঘর থাকে তাহলে ইউ হ্যাভ টু বি মাইন্ডফুল অফ ইট। বাট
There is a balance between cooling and hypothermia.
Yeah.
but
Immediate point
for small areas you don't use ice because the ice can itself cause the ice. For large areas it is the hypothermia.
12 ডিগ্রি সেন্টিগ্রেড বলে ওই যে 60
ড্রেসিং ইজ না ওই the body temperature below 35 degree centigrade should be avoided এটা হ্যাঁ যেটা মাথায় রাখতে হবে। So pain and anxiety management is the important point for burn management because partial thickness burn, particularly partial thickness burn, can be excruciating painful. IV morphine has been the mainstay of management for patient with the significant burn. Benzodiazepine given to treat anxiety. Pharmacological agent used to treat burn pain include opioid analgesic, non-opioid analgesic, nowadays dexmedetomidine, ketamine, NSAIDs, and anxiolytics and anesthetics are used. Anesthetic particularly for the operative purpose during that time. Now come to antimicrobial therapy. There is a next most important portion of the burn management because infection remains the most common cause of morbidity and mortality in burn patients. Individuals who sustain a burn area more than 20% of TBSA are the particular high risk. However, burn wound infection and sepsis can occur in smaller burns. Other risk factors include delay in the burn wound excision, extremes of the age, and impaired immunity. Microbiological factors such as type and number of the organism, enzyme and toxin production, and the motility also contribute. The most common organisms are Staphylococcus and Pseudomonas. Burn sepsis. The fulfillment of the one of the following three criteria we indicate the burn sepsis. It is there is two criteria, one of the following three, and rest from one of the at least three of the following parameters. So,
this is probably this is the area where we are involved in, and this is one of the most difficult areas. Current pathologic infection is confirmed on a culture. अगर तुम घूम থেকে সব পাঠালে তো তোমার আমার স্কিন থেকেও কিছু গজাবে, ওদের স্কিন থেকেও গজাবে। মানে যেরকম আমরা মানে any site there is the colonization, then there is the local infection, and then there is the systemic sepsis. তো এই শুধু ঘুম সব করলে তোমার এই তিনটে ডিফারেন্ট সাইড করতে পারছো না, you have to bring in other criteria.
yes. Actually,
biopsy করে ব্যাকটেরিয়া দেখা তো আমি এখানেও দেখি নিয়ে কথা বলবো এটা পরে যে wound quantitative wound tissue biopsy
টিস্যু বলতে তো পাঠায়
ওটা তো কি স্কিন টিস্যু
মানে উন্ডেড টিস্যু
আর ওরা এরকম রিপোর্ট দেয় করে
আর টিস্যু কালচারের রিপোর্ট
so any one of these things, one is pathological infection is confirmed on a culture that may be wound, blood or urine, or pathological tissue source is identified more than 10 to the power 5 bacteria on quantitative wound tissue biopsy or microbial invasion on biopsy, or improvement of the clinical setting is attributed to a antimicrobial administration. And at least three of the following parameters: temperature more than 102 degree or less than 97.7 degree or 36.5 degree, progressive tachycardia, progressive tachypnea, refractory hypotension, leukocytosis, lab parameter and lab parameter leukocytosis, the thrombocytopenia that occurs 3 days after resuscitation, and hyperglycemia. Any three. Inability to tolerate enteral feeding for more than 24 hours based upon abdominal distension, residual volume, and uncontrollable diarrhea. So these things we have to, if this criteria is fulfilled, we can say burn sepsis. This is as per ABA guideline, but it's also written the as per sepsis guideline, normal medical sepsis guideline, what comes under diagnosis of sepsis, they remain same for burn sepsis too.
Actually, what we see is that the plastic surgeons love silver sulfidazine. और silver sulfidazine लगाले बिल्कुल पैसा भी नहीं आता। ना शॉप पर काम नहीं होगा। तो हम usually don't know कौन सा sepsis से जोड़ना होता है, कौन सा silver sulfidazine से जोड़ना होता है। So तो हम दार है जब हम कुछ मात्रा silver sulfidazine लगाए, I don't know whether it is due to the sulfatizing bit or what, because silver toy, I think it's just for the topical action they are using, but sulfonamides are a definite known cause. Into cotrimoxazole খাওয়ানোর থেকে এই silver sulfatizing লাগালে বেশি cytopenias is seen in the hospital.
So this is the chart that shows the management of the burn wound for sepsis, burn sepsis management, burn wound suspicious for infection. So we have to check whether there is a rapid change of the appearance of the wound, erythema or any hemorrhagic, pyocyanin, discoloration, separation of the eschar or purulence presence or not. If there is nothing such that we can observe, and weekly surveillance culture have to be done. Otherwise you have to see if there is such things is seen along with some systemic sign like temperature, tachycardia, tachypnea, hypotension, leukocytosis or leukopenia, thrombocytopenia, hyperglycemia and feeding intolerance. We have to look for empirical antibiotic therapy and resuscitation and organ support. To burn wound debridement, send the specimen for the culture, sensitivity and histopathology for the depth of infection. If we see to more than 10 to the power 5 organism of tissue and microorganism in the adjacent unburned tissue, then we have to think about invasive wound infection, and in that case systemic antimicrobial is recommended along with wide local excision and debridement at 24 to 48 hours of the any necrotic or infected tissue. If there is a non-invasive burn wound infection, that is the adjacent area is there is no microorganism seen in the adjacent area, then topical antimicrobials is enough. There is no need of systemic antimicrobial. If there is no signs of systemic sign as seen, then we have to see for wound culture. If wound culture 10 to the power 5 organism, this is the important marker. You have to check whether organism is more than 10 to the 5 or not. If yes, then we have to go for again burn wound biopsy, and accordingly we have to treat the patient. Now antimicrobial therapy. So from the previous chart, what we have get to know that from non-invasive burn wound infection, treatment consists of primarily topical antimicrobial therapy and burn wound excision for the unexcised wounds and possibly re-excision of the excised wound. Local management of infected burn wounds include cleaning, debridement, topical antimicrobial agent like sulfur-sulfathiazine, combination antibiotic and chlorhexidine, and the dressing. No role of prophylactic systemic antibiotic. This is according to again for American Burn Association guideline, but in Indian guideline I have saw that is the government guideline. They recommended use of prophylactic systemic antibiotic in case of burn wound too. So adjuvant therapy, prophylactic with H2 receptor antagonist. As we know, there is a chance of Carding ulcer or stress ulcer, and for that purpose, tetanus prophylaxis 0.5 ml of tetanus toxoid. Physiotherapy of the joint for physiotherapy not only for joint, the other body part also. Blood and blood product if necessary only, otherwise not. Hemoglobin target around 8 gram per dl in patient with non-cardiac disease. High dose of vitamin C, studies are goes on that high dose of vitamin C has antioxidant activity, and it helps for burn healing quickly. Anabolic steroid, there is a chance of metabolic process, and that's why there is a hypermetabolic state burn state. So anabolic steroid like oxandrolone are recommended for as adjuvant therapy for burn patient, and beta receptor blocking agent to decrease the tachycardia, tachycardia and the other part of the cardiac sympathetic stimulation.
Last thing হচ্ছে ওই বেগুনে গুণ হয়।
হ্যাঁ এখনো এগুলো নিয়ে চলছে, মানে এগুলো নট রেকমেন্ডেড, এখনো রেকমেন্ডেশন আসেনি, বাট দি ইউজ টু ফলো। Now nutrition, a nasoenteric in tube should be placed upon admission to initiate early enteral nutrition, usually within first 24 hours. Early enteral nutrition has shown to be decrease the bacterial translocation and decrease risk of sepsis, stress ulcer, and improve morbidity and mortality after severe burn injury. In addition, a nasogastric tube also necessary for the gastric decompression, but parenteral nutrition therapy to be avoided as it is associated with increased mortality. Now, metabolic, as I told, the metabolic rate is increases in burn increases proportionally with the burn size. The hypermetabolic response in burn patient is characterized by hyperdynamic circulatory response with massive protein and lipid catabolism, total protein loss, muscle wasting, peripheral insulin resistance, increased energy expenditure, increased body temperature, and risk of infection. All these things.
Increase body temperature কেন হবে? তো hypothermia হবে।
না হাইপার মেটাবলিজম যদি আমরা ওগুলো না করি মানে
কেন হয়?
হাইপার মেটাবলিক স্টেট
মানে see, যত যে কারণে হতে পারে, sepsis হলে প্রবলেম, and skin is a major organ for control of
টেম্পারেচার
which in this
ইনসুলেটর কাজ করে মান যেটা নষ্ট
sorry, temperature rate.
Now nutrition, calorie requirement in case of adult it is 25 kilocalorie per kg plus 40 into percentage of burn area. In case of child it is 60 kilocalorie per kg plus 35 into percentage of burn area. Protein requirement are estimated around 1.5 to 2 gram per kg per day for adult, and for child it is comes around 2.5 to 4 gram per kg per day for children. The major energy source of burn patients should be carbohydrate, which serve as a fuel for wound healing, provide glucose for metabolic pathways, and spare the amino acid needed for catabolic burn patient. Psychological aspect. Burn patients do develop clinically significant psychological disturbance such as somatization and phobic anxiety. Depression and post-traumatic stress disorder are most common psychological problems. Psychiatric or psychological support of the burn patient should be early and routine component of the management. With improvement in the mortality from the severe burn injury, outcomes are focused on measures of function adjustment and community integration. Burn wound management, I have already told earlier, there is a cleaning and maintaining of the burn wound. Superficial burn wounds are covered with dressing materials that aid with skin healing and re-epithelialization. Burn deep wounds are ultimately require burn wound excision and burn wound closure. Excision and grafting is generally performed between 24 to 72 hours after injury. Sometimes if needed, we can do before 24 hours also. Now, combined burn and trauma, there is around 0.5 to 6% cases present, burn patient present with combined burn and trauma, mostly any industrial burn like that, or in any war type of things. The key is to initial management of combined burn trauma patient is that the presence of burn wounds should not be interfere the basic resuscitation and stabilization. The highest priority after airway breathing and IV access in the setting of the combined burn and trauma is the assessment and treatment immediately life-threatening injuries, whether penetrating injury or bullet injury, and then the management of the burn. Usually fracture are the most common, along with the soft tissue injury, head injury, all these things can combine with burn patients. Palliative care. Patient with very large burn and inhalation injury, particularly in the setting of other significant medical comorbidity, are at high risk of the death. So, a patient with BAC score more than 140 to 150, they have high risk of mortality. So, they may forego the specific burn treatment. In this patient, pain and anxiety are controlled. Mainly, so palliative care we have to go for this. This is age plus percentage of burn area. If it's more than 140, that's called the BAC score. There's a reverse BAC score for inhalation injury. That's at 17 more. Chemical burn, the potent.
Say 140 যদি বলে, একটা average adult 50 বছর কি whatever, 60 তাহলে blood area 90 এটা about 89%. আমরা তো যেটা দেখি যে যারা 30% এর বেশি burn 50% পাস করে দেখি।
The potency and concentration of the toxic agent and the duration of the contact primarily determine the degree of the tissue destruction. Chemical burns can be difficult to assess, and the burn that appears superficial may be associated with severe deep tissue injury. As a result, the extent of the injury often underestimated, leading to insufficient irrigation. Toxic chemical absorbed through the skin can cause systemic toxicity, and inhaled chemical vapors can cause both systemic toxicity and lung injury. So, chemical burn management ensure protection of the rescuer and the healthcare worker from the exposure. remove the patient from the area of the exposure. This is mainly at the site. Remove the all clothing and jewelry. Burst the dry chemicals of the patient. Any suitable instrument may be used for that purpose. Irrigate exposed tissue with copious amount of water. Now comes to electric. Rest of management is same as thermal burn. Electrical burn. This is the one of the most common type of burn in medical setting. 4 to 5% are electrical burn. Low frequency alternating current causes more extensive injury tissue than high frequency alternating current or direct current. Because low frequency causes more tissue damage, surrounding tissue damage. High voltage greater than 500 to 1000 volts cause deep burns and extensive deep tissue and organ damage. So electrical burn patient may also present with injury from fall caused by electrical shock, such as long bone fracture, spinal fracture and joint dislocation, along with the electrical burn. So we have to look after that too, that portion too. So ECG, cardiac enzymes, CVC and urine analysis to check the myoglobin due to rhabdomyolysis should be obtained. Anyone who experience any an arrhythmia or any chest pain or other typical cardiac related symptoms are also risk for arrhythmia in 24 to 48 hours of the injury. So continuous ECG monitoring is recommended for electric burn patient at least for 8 hours. So rest of the management remains same as thermal burn. That's all.